So if I'm giving them, say, a continuous glucose monitor, and in the first 2 days, I usually don't rely on those. Continuous glucose monitors are sensing censored glucose and interstitial fluid glucose, not the blood glucose. So there is a lag, and it's not 100% real time, but it's very close to it.
We are diving deep into the link between sleep disorders and prediabetes, diabetes, what questions to ask about sleep in your practice, how circadian rhythm affects hormonal health, what to do with patients who have low testosterone, and so much more. I'm delighted to introduce you to Dr. Chhaya Makhija. She's a triple board certified endocrinologist with nearly 20 years of experience. She's also the founder of Unified Endocrine and Diabetes Care here in California. I've collaborated with her on patient care, and she's just such a wonderful clinician and really a wealth of knowledge when it comes to metabolic health. She's also sharing some really interesting data on lifestyle interventions for prediabetes, things that I'm going to start using in my practice as well, and personally for my own health. If we haven't met before, I'm Dr. Nishi Bhopal. I'm an integrative psychiatrist and sleep medicine physician. This channel is for you, the healthcare practitioner who wants to take a deeper dive into integrative sleep medicine. So if that sounds like you, go ahead and click the like button below, and let's jump into today's episode. Dr. Makhija, I'm delighted to have you here today. We're going to be talking about sleep and metabolic health. Before we jump in, can you tell us a bit about who you are and what you do?
Yes, thank you, Dr. Bhopal. I was eagerly awaiting to be on your channel because you have such amazing information on sleep. And my patients benefit from that. So it's not just my colleagues, but I share your channel with most of my patients because sleep is an important vital sign. So thank you for having me. I'm Dr. Chhaya Makhija, an endocrinologist and a lifestyle medicine specialist. And my goal is education. So I make a tremendous amount of effort with my in-training physicians as well as residents and medical students and my patients to simplify endocrinology, the world of hormonal and metabolic health, and bring it to my patients at my practice, which is Unified Endocrine and Diabetes Care, as well as the community through my podcast, which is Hormones and Health. I'm based in California and excited to share some tidbits and also learn from you more about sleep.
Fantastic. So I'm really excited about this topic because I think people are becoming more interested in metabolic health. There's a lot more awareness now, especially with the CGMs, the continuous glucose monitors. And I think for those of us who, like myself, getting into middle age and starting to deal with some of those issues that come up, there's just a growing interest. And also people are becoming more interested in sleep. So it's a timely topic. So let's start with the patients who are starting to see their glucose levels creeping up, and they're keeping up with their lifestyle, they're working on exercise, they're making dietary interventions, but that hemoglobin A1C keeps on going up, or their fasting glucose keeps going up. What's the role of sleep? How often do you find that poor sleep is a contributing factor to those issues?
Oh, very important. And that's why I started with saying that sleep is an important vital sign. And given your audience being clinicians, we know that pulse, heart rate, oxygen saturation, and so on are important vital signs, but sleep as well. And when you're talking about individuals or non-clinicians seeing their glucose keeping up, it's usually that blood work, which is average of last 3 to 4 months, which is hemoglobin A1C, and one-time fasting glucose. So most of the individuals are population with pre-diabetes, which are undiagnosed, literally walking on the streets, it's 4 out of 5 in United States of America. So most of us don't know. So in those scenarios where you know that your A1C is close to pre-diabetes or just getting there, which is 5.7% and higher is pre-diabetes, 6.5% and higher is type 2 diabetes. Fasting glucose, which is not touching that 125, 126 level, which is type 2 diabetes, but creeping towards it. Stress and sleep becomes very important to assess in those scenarios. Now, I'm not talking about ethnicity, South Asians, family history, all that. I'm sure the clinicians have already assessed. But what's important is to know that sleep and restful sleep, good quality sleep, helps maintain our hormone regulation. And in that, to be very specific, it's the insulin released by pancreas. It's the cortisol released by your adrenal glands. It is also your estrogen, progesterone. So your hypothalamic pituitary ovarian axis, or for men, the hypothalamic pituitary gonadal or testosterone axis. The next one is your adrenaline. When we are sleeping, it's very important to know that we are supposed to rest and relax as well, no matter how much we are putting in terms of hard work, physical and mental. Now, when that is not happening, that is during our sleep period, if it's not restful, as simple as that, it could be for hundreds of other reasons or etiologies, it is going to cause our pancreas to work harder in terms of producing insulin. And why is that? Any fight or flight response that we used to learn about a bear attack, if that is happening now, that is, I'm worried about my bodies now, or I'm worried about future, or I'm worried about what's happening with the war, or I'm worried about what's happening with the gas prices, how am I going to pay my bills? I'm not even talking about your daily mundane routine, but just social stressors leads to that self-induced elevations in our cortisol production. It's physiological, but we are making it appear or rise during our rest period, which is during the sleep period. That cortisol is telling your liver that, hey, produce more glucose. Again, this is normal biology. The signals that liver also produces glucose, even if you're not eating. And now those glucose levels tend to be just at a higher baseline during the sleep period. And that leads to your pancreas that, okay, I need to release more insulin to make the blood sugars normal. Now, for the first few years, you may be fine. Your body is able to cope up with it. Body is a very strong superpower engine that we have, and it will be able to keep you in sync, in harmony, and balance. But over time, the poor sleep, increase in cortisol, which doesn't have to be measured in the blood test, by the way. So we also have the adrenaline rise or the hyperadrenergic drive that is happening because of poor sleep consistently. I'm not talking about this one day or one night or just a travel piece of it, or if you had board exams or stressors for a transient period. But that adrenaline also stimulates your liver or tells your liver that, hey, produce more glucose. So you have your cortisol, you have your liver, you have your growth hormone, telling your liver to produce glucose despite you not eating at all or fasting. And that tends to stress your pancreas in regards to insulin. That's why it is affecting your glucose. And glucose is your main fuel. When we talk about metabolism, it's your engine, your body's engine. That is every cell, how it's working. And the main fuel is your glucose. So that gets impacted. Your insulin release gets impacted. No doubt that sleep directly and indirectly, poor sleep, is going to affect your glucose control, your insulin resistance, your metabolic health for the long run.
Yeah, and it's so interesting because what I also hear through this explanation is that this is all a survival mechanism, right? Like our bodies are designed to keep us safe and to go into survival mode if there is a threat to us, our survival that our nervous system is taking in. And like you were saying, it may not be an immediate threat, but all of the stressors, all of the stimulation that we have all day, it puts the body into that survival mode. And that's why we have these mechanisms where we have this increase in glucose and so on. So when I'm talking to patients, I often use that sort of framing that we don't have to fight your biology or fight your sleep patterns. We need to work with the system so that we can get you back to optimal health. And so I'd love to hear more about how you as an endocrinologist are having these conversations with patients about sleep. Like, where do you start and what sort of assessment are you doing?
Sure, absolutely. The most common scenario that I experience is fatigue. So yes, they may have a thyroid noduling problem, a thyroid hormone disorder. They may have weight gain issues. They may be coming with me for prevention because of insulin resistance. They want to prevent pre-diabetes, prevent type 2 diabetes. Or there is a large group of patients who will just call my office to come in for my type 2 diabetes or type 1 diabetes is worse. I've had poor control for decades and now I'm ready to take charge of it and prevent complications. In any of these scenarios, I'm not going to talk about what your nutrition, what your exercise is, because those are big foundations or large pieces of your foundations for your health. But the first visit, the sleep and how you cope with stress is so crucial. And for clinicians, I know that we don't get in traditional healthcare as much time, but this is a big piece. And usually when I am discussing with their clinicians or giving them talks on prevention, what's more important is train your medical assistants. Other than having them take the vital signs, train them for just getting a sleep history. It doesn't take more than 2 minutes if you're very thorough and you had, just like you talked about the system, just a checklist. So one is, how's your sleep? My patients just get it in their initial patient intake forms, so they are filling it out descriptors. They might call it as good or okay, or someone may just describe it really well. how good you fall asleep or how quickly do you stay asleep? Is there disturbed sleep? And are you able to wake up the same time every day, most of the days, no matter if it's a weekend or a weeknight or a weekday? And your daytime. Am I feeling tired as soon as I get up in the morning, or I'm feeling energetic? The next piece is the daytime, sleepiness, or I feel like I'm just exhausted by that 2, 3 p.m. window. Then comes more important symptoms that patients should be able to also convey. Snoring, or your partner or anyone in your household is talking about you snoring. Gasping, which is patients do notice. Do you use a sleep app? As simple as that. Everyone has smartphones. There are multiple sleep apps which will give you some idea. I won't call them as the sole tool to make a diagnosis, but gasping. And then I personally would go through your bedtime routine, your morning routine, so important. And then your exercise, if you are, what time of the day. And two more things that I don't miss out, which is in the latter half, is your supplement intake. Are you taking supplements? What time of the day do you need supplements to help you sleep? And then the foods, because your bedtime or your nighttime snacks versus your dinner is going to play an important role in how your sleep is. Now, I haven't talked about women's health. I haven't talked about fat lashes, night sweats, and so on. But all of these is basically a checklist for me in my intake, because that is important for anyone, be it a young adult, be it even a teenager, or a midlife or an elderly male or female, which is very important. And it's beyond a simple question that how is your sleep?
What you said is so important. A few things that you said. One is it doesn't have to take a long time, because I think there's a misconception that taking a sleep history could be the whole visit. I could spend the whole 45 minutes or whatever you're spending with the patient on that during the intake, and it doesn't have to. You can streamline it in your practice by having it on an intake form or having your medical assistant do it, or sending the form to the patient after the session, have them fill it out, send it back to you. There's lots of different ways to do it, but it is so foundational. And even these brief questions that you just outlined will give you so much information. And there's also rating scales that can be used as well, like Epworth Sleepiness Scale to assess their daytime sleepiness and things like this. So we can, as clinicians, there's so much we need to do with our patients. So the more simple and systematic we can make it, the better. You also talked about circadian health with the regular wake-up time. So let's talk about that a little bit, especially with those patients who feel wired and tired. They're in this hyperadrenergic state. They have this chronic sympathetic activation, elevated glucose. So let's talk about circadian rhythm. Where do you want to start with talking about circadian rhythm and metabolic health, and then we can tie that back to sleep?
Sure.
As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
Circadian rhythm studies we've had, especially for hormones, we've had there like in 1960s, 1970s, and that's how we learned it in medical school, and then more in-depth in endocrinology. Things are different now. Very different, because we didn't expect those studies and expect that the amount of technology, AI, social media that we'll be exposed to in this era. So one thing I would want to start is just to give you an example, again, because you have clinicians as your audience. Yesterday, I met with a pediatrician as a patient. And the question that she asked me was, can I just check my cortisol and see if I am in this high stress environment? And then the other discussion that she had was, is there a way to check my adrenaline to know that how bad or good my stress level is? That's the education piece that's very important, that when we're talking about circadian rhythm, and that is your 24-hour day and night sleep and wake cycle, it is also your biology, it is your clinical structure, not necessarily everything that can be data-oriented. Yes, we can get a lot of information from the data, but it doesn't mean that you have to get blood work every hour, every few minutes for your cortisol, for your adrenaline, to determine if you are in that stressed. It is how you behave. It is how your body talks. It is how your body is responding that a clinician and even yourself as a patient will be able to tell that the way I respond is just always go. Is always I just need to get things done. Is always I am like I need everything to be perfect. If this doesn't conclude in this certain manner, then things are going to fall apart. So every time I'm talking about either my expectation works versus nothing else is going to be suitable. We are wired in that manner now, knowing that everything is available with instant gratification. We can have results too soon and too quickly in regards to most of the fields that we have. So now that wired and tired, and the hormonal and metabolic part of biology that we'll get into. So normally, if we are behaving with that sunset, sunrise, ain't happening with the summer duration or the longer period of daytime sun exposure that we get. But in general, if our body is suited to wake up at a very specific time, and I think waking up that time, the wake up time, the more consistent it is. Again, you can tell us more about your expertise in terms of studies, but that helps your hormonal or circadian rhythm to be much more in sync and harmony, as opposed to waking up one day at 7 a.m., the other day at 12 p.m., and then a very fragmented wake-up time. That's important for your cortisol, for your growth hormone, for your insulin release, for your glucose metabolic function, the most important piece of the hormonal health. Thyroid, on the other hand, is pretty consistent. It doesn't follow as much of a circadian rhythm. Then other piece is our estrogen progesterone. So our hypothalamic, which is our powerhouse in our brain, the pituitary, also the powerhouse in the brain, and the signals sent to our ovaries and testicles in men also follow that certain pattern. And that's why our perimenopause, menopause females, or even post-menopause, will experience these night sweats, more hot flashes either during the daytime or nighttime. But there is this circadian rhythm disruption that is happening during both things that point. So we know that there is this hormonal secretion which is dependent on our wake up and sleep time. The sleep disorders, disturbed sleep, poor sleep is going to disrupt it. And I'm not talking about a haywire disruption, again, in a short period, but more on a consistent manner, a long-term manner. Our cortisol may just learn to be higher, say at 2 a.m. because I get up every day or every night at 2 a.m., either for hot flashes, for night sweats, or to go to pee every time I have to because of nocturia or increased urination, or I get nightmares, or you are getting into the deep sleep and now you're not getting enough oxygen because of undiagnosed sleep apnea. Boom. Your cortisol is learning to go up higher to cope up with that stress. So it is a natural mechanism. And that's why it doesn't make sense to just keep on checking your blood work that cortisol is making me behave this way. It's the other way around. I have some baseline disorder in either my sleep or other metabolic conditions, which is causing my cortisol to go up higher. So here we know it's a cause and effect. And the reason I can tell you this more certainly is because we have a condition called Cushing syndrome, where either we have a pituitary tumor or adrenal gland producing tumor, releasing too much pathologically abnormal cortisol, right? And that doesn't necessarily only cause circadian disruption or leads to sleep apnea, but it'll also cause very rapid increase in your blood sugars, type 2 diabetes, very sudden onset of high blood pressure, high cholesterol. And then we have some pathognomic signs, which most of the clinicians know about, purpose-tria or the blood pressure fluctuations, and so the way the obesity is governed in those scenarios. But it's more acute in terms of onset, and there is a pathological reason. But that is determined because I have a tumor, and that's leading to this problem. Most of the cases where we are in this hyperadrenergic flight and fight response 24/7 is related to either an underlying disorder, which is not related to Cushing's, or our behaviors that leads to rise in cortisol. So the first goal is to just identify that my sleep is disrupted or my glucose regulation is being impacted. I have insulin resistance. I highly recommend clinicians, and we have enough data to show that we all can calculate something called as HOMA-IR. That is the homeostatic model for insulin resistance. Very simple one test, which really gives an idea of how we can work for this patient in terms of prevention. Now, the reason we have these studies or data available is also patients get motivated that, oh, there is some abnormality here and I could work towards it. So there's a before and after testing that is available. The other piece I highly recommend is continuous glucose monitors. And that is a very great tool to understand the circadian rhythm. It's not diagnostic of their weeping, but it'll really help your patients to understand that, oh, I could work on my sleep. I could see that why the bedtime routine is not healthy for me because it's impacting and leading to this early morning rise in blood sugars. It helps them to really pay attention to, I can go around for post-meal walks because I see a dip in my blood sugars. So it is not about restricting what I eat. It is about physical activity that's important for me after eating. And that's why we have CGMs available over the counter as well. But it is with right education, and we can get into that piece if we are discussing CGM. But that's another tool to understand the circadian rhythm rather than getting these blood tests. And there are many other evidence-based endocrinologists who talk about that test is useless, not evidence-based. It's really not helping you to diagnose something. Yes, you may see some mild elevations in cortisol, but it's physiological. Clinically, we can tell you, because if you're alive, you're able to cope up with the stress, it is because you're able to produce the higher amounts of cortisol to deal with that stress. So again, your body awareness, you speaking with your clinicians asking the right questions and using some tools. I would not go into a home sleep study because that's your realm, the Aura rings, that's your realm of expertise. But all these tools are actually helpful for me when I'm assessing their data along with CGM.
You have just shared so much good information. There's a lot to unpack here. I definitely want to talk about the CGMs and how we can use them, and we'll talk a little bit about some of the pitfalls as well of tracking. But before we get into that, a couple of things. One is I love how you're emphasizing that we don't need to necessarily check your cortisol to be checking all these levels because your body is telling you. And one of the things that we work on with sleep in my practice and in my programs is tuning back into yourself, reconnecting with your body's wisdom and connecting with your intuition. Because like you said, in our modern society, we've lost touch with these sort of basic fundamental physiological signals that our body is. Like patients will tell me they don't know when they feel sleepy. They don't know when they feel hungry. We've lost touch with all of these basic things. So getting back in touch with yourself is an excellent first step because your body will tell you what you need. On the circadian rhythm piece, so another just teaching point for anyone who's listening who's interested in how to talk to patients about circadian rhythm. There was a large-scale study, I think it was maybe 2 years ago, I have to find the exact reference, but maybe 2024, 2025, where they were looking to answer the question of, is sleep duration more important or sleep regularity, meaning waking up around the same time every day? What they found was that sleep regularity, waking up around the same time every day, having a consistent sleep schedule, had a larger impact on morbidity and mortality than sleep duration. So a lot of our patients will focus on getting that 8 hours of sleep every night. That's a whole other conversation, so people can watch my other videos to learn about that. But that consistency is really important. And the reason it's so important is because our sleep architecture follows a certain pattern. And that pattern has a circadian aspect to it. So we get more deep sleep in the first half of the night, more REM sleep in the second half of the night. And if we're waking up at, like you said, 9 a.m. some days, noon other days, I have patients who do that, they're disrupting their sleep architecture. So they're not actually getting all of the stages of sleep that they need in the right proportions. And so stabilizing that is then going to stabilize your glucose, your estrogen, progesterone, all the hormones that you're talking about. Because I think about the circadian rhythm like your train schedule. So the trains don't know when to leave the station if you don't have a schedule. So circadian rhythm is like keeping your body on that schedule. And then now your hypothalamus can tell their other organs, which have their own clocks, what time it is. And then those trains can leave the station at the right time. So that's one of the analogies I use with patients.
Yeah. I wanted to give you this kudos because you mentioned that the reconnecting with yourself, it's actually like real medicine. It's like, again, another foundation piece of medicine. We have handouts on breathwork. We have handouts on training for breathwork. That's coming from, again, me, born and raised in medical school, was in India with the pranayama, the breathwork, and showing them all the studies. And now we have different forms, the box breathing or the hummingbee breathwork of breathing, and that is a chance for us to reconnect. But what's more important is, you had mentioned about one of the questions is that sympathetic activation. That is the fight-or-flight response, which is high 24/7. But those skills of breathing, relaxed breathing is stimulating your parasympathetic, your calm and rest system, right? In terms of simplifying it. And that's so important even for our hypothalamic pituitary and every peripheral endocrine system. For that regulation, other than digestive system, other than sleep, other than the metabolic regulation. So I just wanted to give you a high five for that piece because that's an important part of medicine.
Yes, absolutely. And I think these are the pieces that many of us have forgotten, right? And that we're not really encouraged necessarily in medical school to talk about. It's a wonderful approach that you're taking with your patients. Let's talk a little bit more about the circadian disruption as a metabolic risk factor. What sort of patterns are you commonly seeing in your patients with regard to like late eating, irregular sleep schedules? Maybe they are shift workers, things like this that might contribute to insulin resistance.
Okay, so let's use this as more of the data points because again, we are also having clinicians in the audience and how they could use that as a tool. And it also reemphasizes the fact that patients have something to see, to believe, because then they will definitely make a change. So I'll give you certain scenarios. In any patient who is coming in with, say, prediabetes or a family history of diabetes, they don't have prediabetes or type 2 diabetes, or they're dealing with type 2 diabetes right now, and we've gotten through the entire intake history, and we know that there are certain things that we really need to address rather than jump on prescription pharmacological medications, and they're ready for it. So if I'm giving them, say, a continuous glucose monitor, and in the first 2 days, I usually don't rely on those. Continuous glucose monitors are sensing censored glucose and interstitial fluid glucose, not the blood glucose. So there is a lag, and it's not 100% real time, but it's very close to it. What's important for patients and clinicians to know that it's the patterns that you are assessing or even helping your patients to understand. Now, if physicians don't have that time window to explain how this device works, what they are, and that's where on our YouTube channel, with my medical students, we've created a lot of CGM videos so that patients can be learning about the nuances of continuous glucose monitor. So it's a helpful device, but it has a lot of nuances in terms of not relying on it on certain times and relying on it on certain times. So now what do we see? Say first, second day, if the sensor has a 10-day worth data or a 14-day worth data, one crucial thing that is important to learn is that foods will cause some rise in blood sugars. So don't refrain from foods, no matter if you have type 1 diabetes, type 2 diabetes, pre-diabetes, no diabetes, or whatever age you are. What's important is to learn what is happening over time, not just one time. Once you learn that, we are alive. So just like our EKG tends to have peaks and troughs in a specific patterns, we are supposed to have some peaks and troughs because we are alive with glucose. Having a flat line is never the goal because then we are not alive, right? And that's why to understand that even for patients that we are going to see some peaks and troughs, what's matter is how often those peaks are occurring and how often are we staying in that, say, 70 to 120 or 70 to 140, depending on individualized goals, how often we are staying in that range is going to be important. Now, what I see in patients, and this is again with education, the first 5 days, awareness. Oh, what is my body actually doing? Learn from it rather than panic or by stress. Because I think you and me have discussed this, I don't know when and how, or maybe when you were on our podcast for the guest, is that anxiety from these tools can also raise your adrenaline and cortisol and just worsen the glucose control, right? So don't buy anxiety and stress if you are already educated about this awareness that I'm observing. And then after those first 5 days, you can document, you can see what you're doing, correlate that, and have notes to type in on your apps on these sensors. And now once you start correlating, the first thing I tell them is just start walking after your meals. It could be just running around or walking around the kitchen and living room if it's your neighborhood, or just doing 10, 20 squats after you're done eating. Anything as simple as without thinking about it, you are active. If you're elderly, I have them sit and just dangle your legs or just move your calf muscles as if you're pushing on the gas pedal, both of them, the right and left leg. So anything that is activating your muscles without necessarily using core muscle, because you've just paid to be mindful that it's okay to use the lower body more than the upper body or your core after eating. And that itself brings about 20 to 30 milligrams per deciliter reduction of the glucose. And patients are laughed by that. And I just have this delight that here is a tool, you learned something, and now making a shift in that habit is going to be just way easier and simpler. And you really didn't put much of an effort. It was just reminders. So that's also seen in studies. We have so much of years and years of glucose data that now we make graphs educating patients and clinicians that let them use it to learn about themselves and to make a positive impact as a change in habit for their glucose and metabolic control. The next one is the breathwork that we just based on. Especially as soon as you're up and about, you're awake, that breathwork, just breathing for even 1 minute. Literally, you may just go to 4 or 5 cycles of, say, box breathing or hummingbee breathing and bedtime. Okay, so that's basically my prescription for almost every patient. And you see that stability in glucose for the next few hours. And they're again wowed by it. Now, remember, I reminded them that first 5 days observe. Because unless and until you don't have free data, it's very difficult for them to see that, oh, I changed my breathing habits, my wake up and sleep time habits, and this is what the impact was versus the first 5 days this was. So it gives them an idea pre and post that this has benefits on your glucose control. When your glucose is better, you automatically know that you've improved your insulin sensitivity, meaning you're not letting your pancreas overflow. Okay, so those are a great 2 signals that no matter if you have diabetes, no diabetes, this is applicable to every adult. The next one is hot flashes or night sweats in females. This is where CGM is very useful too, not just as I need HRT to treat it, but also there are certain women who may be on the highest dose of HRTs that still dealing with night sweats or flashes, or they have some big major contraindication where they cannot guess the right dose of, say, estrogens, or even that they are going through a transient phase of night sweats for other reasons, not necessarily the perimenopause or menopause. How to change your bedtime routine, the mindfulness, the reconnection part of it, the breathwork actually helps to stabilize that midnight or the night blood glucose control. Right? So that's a great part of the awareness that happens in this phenomenon. Now, for clinicians who are dealing with patients with type 2 diabetes, one beautiful effect that if you're using CGM that you might see, but to educate your patient, is a dawn phenomenon. So anyone with insulin resistance, anyone with pre-diabetes, anyone with specifically type 2 diabetes, I was talk about, not necessarily type 1, you see this dawn phenomenon occurring. That is, because of their insulin resistance over time, they are having this rise in blood sugar even before they wake up. And that is also contributed by cortisol, by adrenaline, by growth hormone, other than the insulin resistance piece of it. And it's impressive that as soon as patients implement 2 things, one is 3 to 4 hours before going to bed, they're done with their last meal. So no snacking, no dinner, nothing in terms of intake except for water. That helps to improve or reduce that rise in blood sugar. And the second one is just a gentle post-dinner walk and breath. So 3 things that I implement because you're calming the cortisol, the adrenaline piece of the effect on the dawn phenomenon, right? And that really helps with improving the insulin resistance. The post-meal walks just stimulates your glucose muscle that, hey, you need to use all my glucose as fuel, and it's working so that it improves your insulin sensitivity and improves your glucose control. I'm talking about non-insulin, non-medication effects that can happen with these aspects also. And as physicians, wow, you feel like celebrating with them because you feel clinical application or discussions in the data. And that itself is a great educational tool for your patients as well as for ourselves.
I'm so amazed by the 1-minute breath work and the impact that has on the glucose. I didn't know that. I encourage my patients to do it for anxiety and for sleep, of course, but I didn't make the connection with the glucose aspect. So for my patients who do have insulin resistance and stuff, I'm definitely going to start incorporating that. That's so interesting. And I'm curious too, what CGMs do you recommend?
Yeah, sure. So there are FDA approved and over-the-counter continuous glucose monitors. So just in general, if I keep individuals with type 1 diabetes out of our conversation because they have really great ones, but in general, any one of you as adults can use a Libre 3 Plus, that is Freestyle brand, or Dexcom G7. These are two different brands, but they're almost the 14-15-day version of the continuous glucose monitors. And one tip for clinicians is that if your patients are interested, they just need a prescription. They can go to their websites and get a free trial. So you don't have to go into the insurance. Both these companies provide one sensor for free as a free trial. And they could just watch the YouTube videos, or I can share my channel where they can see step by step on how to use it, why to use it, what are the nuances with it. And bingo, they themselves are empowered to use it. These are prescription devices though. In terms of over-the-counter, both these companies have over-the-counter availability also, but they're not over-the-counter retail pharmacies. They're over-the-counter online. So these sensors can be bought by patients themselves, and they could use it, apply it for themselves. The only thing is that over-the-counter has less bells and whistles. And the accuracy is different in terms of the prescribed version versus the over-the-counter. So if you know the nuances as a patient, not find, again, anxiety, fear with the over-the-counter versions, and you have good education, then you can also use these over-the-counter non-prescription sensors or CGMs to learn from the patterns. Again, not just one glucose, but from the patterns, and improvise your lifestyle changes.
And just to underline that point, the point is not to use these trackers, whether it's a CGM or in sleep, we're using Oura Ring or these kinds of trackers. The point is not to look for perfect data or start to get anxious about it, to chase numbers, but to give you information so that you can use that to make these lifestyle changes and see and be a little bit experimental and be curious about yourself, or as the clinician, be curious about your patient and see what's going on for them. Okay, great. So I want to change gears a little bit because you had mentioned testosterone earlier. And I'm curious about hormonal shifts in men as well. We've talked a little bit about women. So how does chronic sleep deprivation or sleep issues or untreated sleep apnea, for example, in men affect testosterone and their HPA axis?
Absolutely. For men, the two most important concerns in general are erectile dysfunction and low libido, which they might not bring about in conversations, but they are necessary for us as endocrinologists to discuss or to ask in our regular visits for evaluation, because that's the metabolic hormonal. Now, why is that important? I won't get into the details, but the most common causes for erectile dysfunction is vascular, that is, it's blood flow, and it's not the testosterone level. And the blood flow gets affected if our metabolic dysfunction is going or is getting worse and worse. That could be the heart disease, that could be high cholesterol, that could be prediabetes, type 2 diabetes, insulin resistance, obstructive sleep apnea, which is undiagnosed or untreated. And that's affecting or impacting the blood flow, which leads to erectile dysfunction. So it's very important for us as clinicians to pay attention to their sleep history, because it's mind-blowing that so many of my patients will have even mild sleep apnea and other metabolic dysfunctions have been taken care of, have been addressed, or they're getting the right pharmacological intervention. But this piece, if not treated, will still impact the call or the effect, which is the erectile dysfunction. The other piece is even deviated nasal septum. So I've had several patients, men, who talk about snoring and may not have very obvious sleep apnea diagnosis. Like it'll just be towards it. It's not mild, it's not moderate, it's not severe. And lo and behold, I have the ENT CDM, and it's the deviated nasal septum is blocking it almost by 90-95%. Fix it, great improvement in erectile dysfunction without medications, right? So knowing that that part of the gonadal system is affected by metabolic health is very important for men and women to understand, so that they're getting the right evaluation rather than thinking that, oh, it has to be my testosterone and let's just get these injections or replacement, but it ain't going to fix your actual baseline problem. until you don't get evaluated. The second thing is low libido. And that is an important aspect. Again, all these conditions that we talked about will negatively impact or cause low libido. But that's when testosterone can flare away. That is low testosterone. So all these metabolic conditions, which are undiagnosed type 2 diabetes or untreated or suboptimally treated type 2 diabetes, prediabetes, insulin resistance, obesity, which is unaddressed, any sleep disorder, literally any sleep disorder which is not being addressed or not treated, tells our brain signal, which is your hypothalamus, that more important for me is to be alive and to sustain life. And for that, I need my cortisol, I need my adrenaline, I need my thyroid. I don't need testosterone or estrogen to survive. So that's the basic flight and flight response mechanism. So those signals are being fed to your hypothalamus. Hypothalamus tells your pituitary that, oh my gosh, this body is under a lot of stress. And stress is all those metabolic dysregulation, including how possible undiagnosed sleep disorder. And it tells that I don't need as much stimulation for testosterone. So it tells pituitary to just reduce the signaling for that, because right now I need more energy, more signaling focused on the other hormonal balance and regulations. And that leads to reduction in the production of testosterone. That's called secondary hypogonadism. It's called secondary reasons for low testosterone. That cannot be fixed by just giving you testosterone, because we haven't looked at the secondary cause, which are all these conditions. Now, in most of these scenarios, while we're addressing the secondary causes, I don't tell patients that, okay, treat your diabetes and your libido is going to be fixed within a 1 month period. It takes time. If we've had type 2 diabetes, I know that at least 5 years prior, you've had this process going on. Same thing with obstructive sleep apnea. By the time you get evaluation or you're getting untreated or you need a CPAP, you're not waiting to just let you deal with erectile dysfunction or low libido. I had a lot of in-depth conversations with the right sexual medicine specialist and urologist on our podcast regarding erectile dysfunction and low testosterone. But in general, medications like Cialis, very helpful as a daily intake in terms of helping patients with erectile dysfunction while you're treating these chronic diseases. For low libido, medications like Clomid or clomiphen citrate used in conjunction while you're treating all the secondary conditions can help stimulate the hypothalamic pituitary testosterone axis, and they probably don't need, most of the times, a testosterone replacement therapy for these conditions. Why this is important is, in one line, I'll tell you that if you were a male listening to this conversation and knowing the fact that if you're not treating the secondary causes, including addressing your sleep, the metabolic dysfunction, using testosterone therapy by itself without fixing those conditions will just lead to testicular atrophy. So you're not gaining in the long term, and you may not feel the best, even in the short term, if you blindly accept testosterone therapy without questioning the why and getting the evaluation for the why.
Really important points. As a psychiatrist and sleep doctor, I see men in my practice. They're coming in for insomnia or anxiety or depression, things like this. And I have seen patients go to these clinics and go and get testosterone prescribed without really getting a full workup. So I think what you've highlighted here is really important. And for the clinician who is working with the male patient who is maybe struggling with these issues, what are some of the workup steps, especially for someone, who is a psychiatrist or who is in a different specialty where they're not necessarily prescribing Cialis or Clomid and these types of things? What are some of the basic steps they can do in the workup, at least, to get things started for that patient?
Sure, absolutely. So I'll move away from history intake, because once you've gotten these symptoms and you're suspecting that, something's wrong with, say, even the testosterone aspect of this, or hormonal aspect for men, you could definitely start with an evaluation other than your physical examination. Is getting the appropriate hormonal test, which has to be fasting. Very important that you focus on more commonly 7 to 9 a.m. period when they're going to the lab to get blood drawn. If they have a usual circadian rhythm, it makes a difference if they have graveyard shifts or there's inversing night shifts for the illness period, then we may have them get labs done, get 2 intervals. Fasting, there's a testosterone panel. So make sure you're getting total testosterone, free testosterone, including sex hormone binding deodorant. It's going to be very important to calculate the right free testosterone. Then comes the pituitary blood test because it has to go hand in hand. So LH, which is luteinizing hormone, FSH, which is follicle stimulating hormone, is going to be crucial, and prolactin level. In every patient for their first initial evaluation, prolactin is a hormone coming from the pituitary gland. So this is basic. And then I would make sure that you're also getting your hemoglobin A1C, including the metabolic panel, which is a comprehensive metabolic panel. Get a baseline CBC because you want to make sure this patient's hemoglobin is normal to rely on the hemoglobin A1C. Because it's very notorious that there is a certain condition called hematochromatoses, which can cause secondary hypogonadism, growth testosterone. So you're covering these basics for the patient, and then comes if you were also looking at the lipids, apoprotein B, lipoprotein A, depending on your specialty, it'll help you to figure out if these are contributing to those secondary causes in general. We also get a body composition done, but this might be too specific for individuals. But primary care physicians, anyone thinking about prescribing GLP-1 receptor agonists for treatment, should get a baseline body composition for these patients to know their visceral fat, to know their basal metabolic rate and muscle mass. Higher the visceral fat, more the inflammation, and it's likely contributing to that secondary hypogonadism piece of the jigsaw puzzle in your patient.
Fantastic.
That would be enough. Let's be getting into more specifics.
I think that's great. So helpful. And gosh, we could keep going and going, but this has been so valuable. I'll add one more thing just to double click on something you said earlier, which is about having a low threshold for testing for sleep apnea for men and women. And it can show up in a very insidious way. It doesn't always show up with the classic symptoms that many of us are taught. In patients with a high pretest probability, obesity, 17-inch neck, then yes, they may show up with those classic snoring, gasping arousals. But for many of our patients, it looks like fatigue. It looks like insomnia. It can look like depression. It can look like that hyperarousal, that wired and tired sort of picture. And remembering that sleep apnea can fluctuate from night to night. So you might need more than one sleep study. So that initial sleep study, if it comes back negative, that's not necessarily diagnostic. It just didn't capture what was happening that night. Just tying that all together. So this has been so valuable, Dr. Makhija. Thank you so much. Where can people find you if they want to work with you?
Absolutely. Thank you so much. This was a very fun conversation to have with you and also learn from you. I have a social media channel, which is all at Chhaya Makhija MD, and YouTube channel sharing all these tidbits along with our podcast, which is Hormones and Hope by Dr. Chhaya. And for consultations, we have our website, unifiedendocrinecare.com, for anyone residing in Canada.
Amazing. Thank you so much. So I'm definitely going to bookmark your CGM series on your YouTube channel and start sharing that with my patients. I didn't know you had that, so that's a great resource. So I recommend to everyone to check that out. And we have shared some patients, and I really love your approach to metabolic health. And it's just really been a pleasure to collaborate with you on those cases. So thank you for sharing your expertise with us today.
Oh, absolutely. My patients love this information. Your coaching programs. And they've gained tremendous benefits here.